let's move on then to GP. A lot of people generally, when we have these conferences and we talk to doctors who have finished PLAB 2 or close to finishing PLAB 2, there's often a discussion between GP and core medical training. Unless you've got a specific want to do a specialty that you've always wanted to do, whether it's orthopedics or surgery or medicine, for example, or A&E, for example, emergency medicine, there's often this debate between GP and core medical training. So let's focus now on GP, now that we've done the core medical training side of things. So for those of you who don't know, again, welcome. I'm Dr. Amin Arora, portfolio GP now in full-time med ed, and a lot of my training and help in terms of getting doctors through exams is all about the GP pathway. So yes, we help people going all the way back from med school through to PLAB and getting into GP training, but it's the GP training thing is where we started because I was a GP myself. So lots of my previous roles have been around GP training itself. So hopefully this talk can cover a few common questions that we tend to get about the GP pathway. So my aim for the next 35 minutes or so is to cover a bit about what is general practice in the UK, because it's a specialty that's not known a huge amount of if you haven't got general practice in the country that you're from. Some pros and cons, because we often get asked about what are the benefits and drawbacks of doing a career in general practice in the UK. A bit about the application process for those of you who are thinking about applying for the next couple of rounds that are coming up in the future, and then a bit about the assessment, the MSRA that you need to do in terms of getting into GP training itself. And the blog has just gone out in the chat about how to get into GP training, what it's all about. So please do save that, maybe to have a little look at a little bit later on, where it goes through all the steps I'm going to be going through in a bit of detail now. So let's do a quick overview firstly about what is general practice. Like I said, it's an area that people don't know too much about if you haven't worked in the UK or know people working in the UK. So in the UK, you generally can split your medicine or the provision of medical care into primary and secondary care. So primary care is anything that's based in the community, so general practice in essence, and primary care can involve GPs, but also lots of other people in the general practice team working together as the primary care unit. And the majority of doctor-patient contact, the majority of medical care in the UK is covered in this primary care bubble, if you like. In other countries, you'll find that the majority of work is covered in secondary care, but in the UK, it's predominantly in primary care. And then you have the secondary care system, which is basically the hospital's care system. And the primary care system is designed to take the bulk of the work and then forward on any specific things that need further intervention and further care in secondary care. So in other parts of the world, for example, if you have a knee problem, you might go directly to a orthopedic consultant who specializes in knees. That doesn't work in the UK. The work in the UK goes to the primary care system first, the GPs. They would probably be able to handle 95% of those knee pain or knee presentations, but 5% or 10% will be forwarded on to secondary care. And that's kind of how it's split in the UK. So general practice is essentially primary care system. So like we said, the bulk of the UK doctor-patient consultations happen in primary care, and it's known as the gateway to the NHS because, like I mentioned, most of the initial primary consultations around new problems come to GP, and the primary care system can therefore act as a gateway to only forward on those that need specialist intervention, specialist treatment, etc., forward to the secondary care system. There's a big shift in the terminology that's been happening in the last 4 or 5 years. So if you look at a GP, general practitioner, other terms that you might now be hearing about are consultant generalist or a consultant family physician, because these terms are becoming more synonymous with general practice. You probably didn't hear these terms maybe 3 or 4 years ago, but they're becoming more and more popular now. And as some people know, some people may not know, a community clinic or a GP surgery in essence works as an independent business. So you are working as a GP in your own clinic. That's your own independent business. It's still part of the NHS, but you would run it as if it's your own clinic, and then you would forward on patients to secondary care as needed. So that's a very brief overview of what general practice is in the UK. And if you apply for GP training, you're applying to end up being a consultant generalist or a consultant family physician. So the terminology, I think, is important to understand before we move ahead. So what are some of the pros of general practice? Now, you have some of the pros about general practice training, For example, GP training is a shorter training program than some of the other specialties. So currently, GP training is 3 years, or in some instances, 4 years. Whereas if you consider a lot of the specialty training, it might be 7 years or 8 years, for example. I think GP training is going to expand because the model of 3 years was created in the 1980s, and probably now you need a lot more in terms of training to be a GP. But still, currently, it's that 3 to 4 year training program. A lot of people choose general practice because of the flexibility. General practice is one of the few specialties where you can say, I want to work 3 days clinically in general practice, but I want to do 2 days something else. Or I want to just work mornings in general practice and afternoons doing something else. Now, that something else might be another medical specialty or another medical interest. So this is where we hear the term of gypsy or GP with a specialist interest. And that could be in a different medical field like dermatology or women's health or endocrinology or whatever it might be. So you might be doing 2 days a week in that and 3 days a week in general practice. The flexibility is something that often draws people to general practice. Range of medicine, like we said, there are very few specialties where you're going to see that depth of different presentations. You don't know what's coming in the door. Of course, emergency medicine is one of them. Acute medicine, to an extent, is one of them. But general practice really is that complete broad range of medicine. You might be seeing some psychiatry in patient one, orthopedics in patient two, cardiology in patient three. You really have to have that interest in medicine as a whole. And again, that's another reason that people often gravitate towards general practice, because they don't have that burning desire to do orthopedics or that burning desire to do cardiology, for example. Another big draw, really, that people talk about in general practice is this continuity of care concept, where sometimes in hospital specialties, you'll see a patient at a particular part of their journey, you'll have the intervention, whether it's the operation or the specialist medication that's involved. And then if that patient improves, they go out of your system again. So you never really see what happens 2, 3, 4 years down the line unless you're managing a condition that's needed regular contact. Whereas in general practice, you will see people right from the beginning through to initial management, through to maybe a referral. You'll see them back after secondary care treatment. You'll follow them up 6 months down the line. So you get to see that story generate. And a lot of people like that type of medicine where you're seeing somebody over a long period of time, often years. Sometimes you might have a patient over the next 20 years that you follow up and you see every bit of their journey. That continuity of care, that knowing their whole story, is something that you don't find in too many specialties. General practice does definitely have that in place. Choosing your working time, I mentioned there's a lot of flexibility around the times that you work, the days that you work, the clinics that you want to do or versus not do. Whereas when you're in a specialty in hospital, for example, you're very much dictated by rotas. So that's another benefit that people often choose when it comes to general practice. And then, like we said, you can develop other skills in general practice. A lot of people do other things, whether it's sports medicine or minor surgery or pediatric community clinics, for example, and you get space to do this and develop the other angle of specialty, as opposed to when you're in a consultant role in a hospital. It's very hard to sometimes find time to develop other side points because you're on this rota, a 7-day rota system. So there's a couple of pros that people, certainly a lot of these drew me to general practice. My father was a GP, so I saw a lot of those positives from a very young age. Let's talk about some of the cons, because obviously general practice is not for everybody, and it's important to see these cons for what they are. And a lot of the cons, I would say, are perceived because I've been in general practice, so I know that maybe some of them are not quite as they are portrayed. But let's try and run through a couple of perceived cons. So some people feel that there's not you miss your acute work. So if you're a doctor who really loves being on the front line, A&E type emergency presentations, then maybe general practice is not for you. But the caveat to that is that you do obviously see acute work in general practice. Often people's first presentation when they're acutely unwell is to the GP. People may not realize that they're actually really unwell and they come to a GP, and it's our job to pick that up and put in initial management and then refer on to the relevant services. So in some aspects, if you're that type of doctor that really wants to be fast paced all the time, intervening, moving on to the next patient, then maybe GP is not for you, but you do still need your acute skills up to date. And an acute MI could walk through the door. A patient who's having an acute allergic reaction that turns into anaphylaxis could be right in front of you. Tension pneumothorax could walk into your clinic. So you still need to know your acute work and you still will see it, but it's not as if you're in emergency medicine where everything is coming in as an acute presentation. Sometimes people query this loneliness con, that if I like working in a ward environment. I like working in a team environment. I like constantly being with 4 or 5 other clinicians making decisions together. And I do see that aspect as a possible con. Sometimes in general practice, well, you are working in your own room for a starter. You are seeing these patients on your own. But sometimes the way general practice is going now, there may be a huge GP clinic where you have 10 to 12 GPs working at the same time alongside nursing staff, practice nurses, district nurses, physiotherapists, MDT. So that loneliness can or cannot be a con, depends on how you look at it and how you prefer your working system to be. Some people feel that the responsibility level is quite high in general practice. So sometimes, for example, on a Friday evening, you may be the only person in that building clinically, and someone walks in, and you have to be able to take the responsibility to either see that patient, initiate management, make a decision as to whether I need to admit this person to hospital or not, bearing in mind the weekend is coming up. And you've got to be able to take that responsibility on board. And we don't often see that in other specialties because when you're in hospital, people are in hospital, there is always somebody around on the wards covering, whether it's at night, whether it's at weekends. Whereas in general practice, sometimes you have to get used to taking that responsibility on. And if you're somebody who goes home and worries about patients quite a lot, then maybe this might be an area that can be seen as a potential con. De-skilling, sometimes people feel that in general practice, am I going to get de-skilled? Am I going to forget how to put in anesthetic drains? Am I going to forget how to do chest drains? Am I going to forget how to do those procedures that you're doing day in, day out in hospital? And yes, there is an argument to that. It depends how much you feel like you want to be doing these kind of things all the time. But there are other skills that, like we mentioned earlier, you can develop in general practice. So, for example, you can still do minor surgery procedures in general practice. You can still be a GP with a specialist interest and do those skills, whether it's endoscopy or colonoscopy or things that you particularly enjoy. So, yes, you can argue that certain acute skills are going to be reduced in terms of your ability to do them in a community setting, but then you can still keep some skills on side depending on how you prefer to work and what your interests are. And sometimes this is a bit of an outdated perception now. Some people think that all you see in general practice is coughs and colds. It's not real medicine. Like we mentioned earlier on, you are seeing 90 to 95% probably of healthcare in the UK. So you are seeing the whole spectrum of clinical pathology. And yes, you may be seeing a lot of what we call the worried well, who come in just for reassurance, for mild, what we call mild presentations, but also you are often the first person to see the angina. You're the first person to see the suspected cancer. You're seeing them at a very early stage. So your clinical acumen has to be a very high level in general practice so that when you see 10 people in a row with abdominal pain, you're not going to miss the one that says suspected appendicitis, and you're not going to miss the one that says suspected upper GI cancer. So again, it's a lot of how you see it. Yes, you may see a lot of worried well, but also you need to be right at the top of your game in terms of not missing those very early signs that may later present to something like an A&E setting. So yes, there are cons, there are pros, but some doctors are very much, yeah, this is me. Some people think that, I've got a burning passion to do something completely different, which is fine. So it's just worth bearing these in mind before you think of applying to general practice, because a lot of people apply to general practice without really understanding A, what primary care is in the UK, and B, they haven't really thought through whether this is the type of doctor that I want to be for the next 30, 40 years in the UK. So that's an important internal thing to think about. Very briefly, my GP journey then. So I was born in the UK. Father was a GP, so all I saw from a very young age was general practice. I was forever going into my father's clinic and kind of sitting in the reception area and getting used to general practice. So general practice was always going to be the area that I wanted to be. As I developed, I went to med school. I started to want to be a cardiologist. I thought I had a burning desire to do this. But then when I actually did a placement in cardiology, I realized this is not really for me. And my kind of setup was more geared towards the general practice side. Did my medical school, did GP training, and became a GP in 2010. And then since then, I've had a lot of clinical roles within general practice, but I was developing my other roles as well, particularly within medical education and starting a company as well. And I've been full-time medicine in 2018. So it's a great example of how you can become a GP, but you can also develop other skills. And in my case, it was medical education, but in some other people's cases, it could be GP with a specialist interest in another clinical field. And again, there's lots more what we call portfolio working these days in the NHS, where people do a little bit of this, a little bit of that, a little bit of this. And the easiest place to do that is in general practice for sure, because you have that control over how much or how little you want to work in that particular field. Now that I've talked a bit about what general practice is and a bit of the pros and cons, let's start to go through some of the the basics about training, the application process, etc. So GP training basically, so minimum 3 years as a specialty GP trainee. It's called GPST, GP specialty trainee. Sometimes there are some 4-year programs as well. And of course, some people go less than full time. So it could take 5 or 6 years, depending on your own program. But generally, currently 3 years is the minimum. And a lot of people come in and out within 3 years and end up as a GP. In that 3 years, you're going to be going around different rotations. Around 18 months of your 3 years are usually based in general practice, and the other 18 months are based in hospital rotations. So hospital rotations that are related to general practice. So you might do 4 months in pediatrics, you might do 4 months in elderly care, you might do 4 months in psychiatry, there might be a rotation in emergency medicine. Again, the program is developed so that you get experience in general practice, but also in hospital specialties as well. So, like we said, based on things that are going to be useful to you when you're a GP in the future. There are some innovative posts available where you do kind of half the week in GP and half the week in pediatrics, for example, but usually you do full rotations for 4 or 6 months and you rotate through these. Your last year of training, the final 12 months, is usually your final GP training placement. So for your last year, you're fully in general practice, but up to that point, you're doing rotations either in GP or in hospital. Each year that you finish, you need to clear what we call an ARCP. So it's an assessment of performance from one year to the next year to allow you to jump to the next year. This is the same in all specialties, not just general practice training, whether you're doing core medical training, radiology training, etc. You'll need to clear an ARCP at the end of every year, and GP is no different. But then one of the differences in GP training is that you cannot complete GP training unless you complete your MRCGP qualifications and membership of the Royal College of GPs. So to do your MRCGP, there are 2 exams to take, and there is constant workplace-placed assessment. So you need to be completing those exams, and currently they're called AKT, so MRCGP Part 1, and SCA, MRCGP Part 2. So you take those exams within training, and you have to pass both of those in order to complete GP training. And at the end, if you have completed your MRCGP exams, if you've completed your MRCGP assessments in the workplace, then you will receive your CCT, your Certificate of Completion of Training, and that is when you're a fully qualified GP, in the same that you'd be a fully qualified cardiologist or fully qualified pediatrician when you get your CCT for those specialties. So that's generally the process that you'll be looking at if you're applying for GP training at present. That can change. So like we said, you have GPST1, GPST2, GPST3. This is the general names that you'll be given. Sometimes there's a GPST4 as well in certain placements. And then like we said, you have your AKT exam to take. You can take that from GPST2 onwards. And then your final exam, your SCA exam, which you can only take in the final year of GP training. And if you complete all of this alongside your internal assessments, you end up being a GP at this point. And every 6 months, you have what you call an ESR, which is an educational supervisor review. And then every year, you have an ARCP, like we talked about. This is similar to all specialties, not just general practice training. So what's the eligibility criteria? There's a lot of crossover in some of the talks that we've had earlier on, because in essence, to apply for specialty training in the UK, whether it's GP or something else, a lot of the eligibility criteria are going to be pretty similar. You need to have your MBBS or equivalent degree. You need to be eligible for full registration and hold a license to practice from the GMC at the time of the intended start date. So some people kind of factor that in terms of when would I be applying to start and would I have my GMC license by that particular point. Like the other specialties that we talked about earlier, you need to show that you have evidence of what we call foundation competencies in the 3.5 years preceding your start date. So again, you think about, say I'm thinking of starting in August 24, I need to prove that I have foundation competencies in the 3.5 years before that point. Now, if you're in a UK training system, this will happen naturally by way of going into the UK Foundation program. International medical graduates sometimes apply for the UK Foundation program so that they will automatically again end up with those competencies completed, whereas most international medical graduate doctors, like we heard in the previous talks, will demonstrate this achievement through using a CREST form, the Certificate of Readiness to Enter Specialty Training. And this is 2024, sorry, we haven't changed it. The new version, like we mentioned, has been released. So this form will show that you have evidence of achievement of foundation competencies, as long as it's in the 3.5 years before your start date of training. You need 12 months of medical experience after full GMC registration or equivalent post-licensing experience. So that 12 months can be outside the UK or inside the UK as well. You need your general work eligibility to work in the UK. So this is not a doctor thing. This is just you need to be eligible to work in the UK as a general. And for GP training, one thing that's slightly different to other specialties is that you need to have a UK driving license, or you need to demonstrate that you have equivalent transport arrangement. Now, this is important because in GP training, you may be doing home visits, going to see patients at home. So you need to prove that you have the ability to do that in some format. And that's going to be something that's going to be looked at as part of the initial part of application process. That's one thing that's slightly different to go forward. Okay. So what about the application process itself then? So there are two rounds of application. This matches, again, a lot of the other specialties, but some specialties only have one round per year because the numbers that they're looking for are lower, where something like GP has two rounds per year. There used to be a third round, or 2A or 1B, or however you want to look at it. But currently it's two rounds per year. So this is for an August start. That's where the majority of training rotation starts, or August to August to August to August. Whereas there was a smaller round every year for February start. So people start kind of halfway through, but still have their 3 years starting from that point. So two rounds per year, coordinated by the GPNRO or ORIAL, so similar to all or Health Education England application processes. And the application process is there to allow you to show that I have the right abilities to apply for GP training. So there's something called a GP-ST1 person specification document, similar to other specialties, and it tells you what are the kind of things that we're going to be assessing you for in the application process. So you apply through the ORIAL recruitment portal, similar to other specialties that we've heard about earlier on today, with an electronic application form. And at some point during the process, you are supposed to rank your GP training programs across the UK in terms of this is my first choice, second choice, third choice, fourth choice. And you can put as many or as few areas as you want on that ranking list. But I would only put areas that you're actually prepared to work, because you are going to be ranked according to your performance in MSRA exam, and you're going to be offered a place based on what your own ranking was and how well you did in the exam. So what you don't want to do is put put every single part of the UK on that list, and then you end up given a place in a place that you don't actually want to work. So it's really important to get that bit right, that balance of having as many different places as you can to maximize you getting in somewhere, but only putting in those places that you really would actually want to work in, rather than just putting everything down for the sake of it. So once the application window closes, at that point, you're invited to register with Pearson VUE. Pearson VUE is the area that you do the MSRA exam in. So like we heard earlier in the radiology talk, you can do the MSRA exam as a computer-based exam. You can do it in multiple different cities across the UK, and you can take MSRA abroad as well. So you register for that, and then you go through a process of what we call long listing. So once you've done your application, then the HEE team will go through your application itself. If you meet the eligibility criteria and everything looks good from that point of view, then you're invited to sit the MSRA exam. So you don't apply for the MSRA exam, you apply for specialty training. And if you meet the eligibility criteria, you're then invited to sit the MSRA. So it's important to get that bit right. You don't apply for the MSRA itself. So let's talk a bit about the MSRA then, because this is the exam that a lot of you guys are already preparing for right now, particularly if we're doing the January exam. So the January exam that's coming up is for August 2024 start. So important to remember you've got your timelines right as to when you'll be taking your MSRA. So MSRA, like we said, is a computer-based exam or assessment taken at Pearson VUE test centers if you're in the UK. There are other test centers that are utilized if you're doing it abroad. It assesses various competencies outlined in that person specification document that I talked about earlier on, so the GP-ST1 person specification document. Now, in general practice, there is only the MSRA exam that is used to determine your rank. So we heard earlier on in radiology, for example, you do the MSRA, but you also have a portfolio and you also have an interview. In general practice application, everything is based on the MSRA. There is no interview. There is no stage 2, stage 3. There used to be a stage 3, which was an interview. But post-COVID, they took that stage 3 away, and everything has now become based on MSRA. So there are only a few specialties that use MSRA solely as its application process. General practice is one, psychiatry is another. We'll be covering psychiatry after lunch. But it's important to remember that in GP, the only thing you have to compete with somebody else is the MSRA. So you have to really, really do well on the MSRA. In other specialties, you'll do the MSRA, but only 10% of your application, for example, will be based on your MSRA score. Other things would make up the rest of the percentage. Whereas in GP, it's all about this exam. So you really need to prepare for it really, really well. And in the MSRA, there are two main papers. There's a professional dilemma paper where you have these situational judgment test questions. These are the type of questions that people often struggle with because they're not typically the type of question that you have done in your primary medical degree. Whereas if you've trained in the UK, then you might be used to doing these types of questions. And then you have the second paper, which is your clinical problem solving paper. And as Dr. Shidantu talked about in the radiology talk, people often relate this to kind of PLAB 1. So your base is quite good already because you've done PLAB 1 quite recently. People don't tend to struggle too much with these. It's the professional dilemma paper that people often struggle with. The duration is around 3 hours. It's quite a long exam, two papers done back to back. There's no pass mark as such. There's no maximum score that you need to be achieving. It is completely based on how well you do compared to your peers. So, like we talked about with MSRA, every single mark counts. It's not that you can just settle for, well, I just need to get the pass rate and then I'm happy. You need to do better than your colleagues so that you get maybe the last space in the area that you applied for. So it's a really competitive exam, and therefore your preparation needs to be top notch in terms of going forward. We'll talk about how to prepare for MSRA in a second. And then, like we said, your score ultimately determines the rank that you get, and therefore ultimately the area of the UK that you get offered a place for GP training. And if you haven't done well enough compared to your peers, then you may not get an offer at all if you've maybe put only 3 or 4 places that you want to work in. So it's that balance between, like I said, how many places am I prepared to put down in terms of where I want to work versus how well you do compared to your peers. And that's why MSRA preparation is something that shouldn't be taken lightly because it's an important part of your whole application process. So we talk a lot about hashtag Campus Will Pass out Aurora. So for those of you who've used for PLAB 1 and PLAB 2, you know we talk a lot about this, and it's about getting that mindset right. How do you prepare yourself best to get that highest score? And in MSRA, like we said, it's really important to do that because it's such a competitive process. We talk a lot about dual-based approach. So there are different ways of preparing for MSRA, but we talk about this balance between knowledge build-up and focus on technique. So a lot of people do a lot of questions and do a lot of question banks, and that's great. But you need to have a strategy for building my knowledge. So whether that's going through guidelines, whether that's reading GMC Good Medical Practice, like we mentioned here, whether it's finding some kind of resource that teaches you the knowledge base that you need for MSRA. And secondly, technique. So when you do your questions, making sure that you're looking at, am I getting my technique right? Because like in PLAB 1 or AKT in the future, the technique side of things is very under reviewed sometimes. People do a lot of work, a lot of reading, a lot of questions, but they don't focus on that side of things. And again, that dual based approach is really important. Making sure you have your guidelines in place, your UK guidelines, making sure you're going through things like NICE CKS, for example, and then your GMC Good Medical Practice. This is the knowledge side of things that you need for the SJT paper, and understanding what does GMC expect of me as a clinician? What does GMC expect me to do in this type of situation? That is what your knowledge needs to be built up in order to do well at the SJT level. And again, that plus your technique can often lead to a good score. Social media, there's lots of stuff around social media, particularly I'll show you in a second how we teach for MSRA through social media. A lot of you guys hope they're using us already. There's a few links going out in the chat for this. And also really important with MSRA, it's important to get somebody who you can prepare with. Often in things like PLAB 2, people are very good at finding study groups and people to prepare with, but then they go off to MSRA and they kind of go on their own. And it's just like any other exam, really. You don't want to be doing this on your own. You need people to be pushing you and making sure that you're doing the right things. And again, we're quite involved in getting study groups set up for MSRA. So there's a lot of support that we do give for MSRA, and I know a lot of you guys are using our MSRA resources already for the January exam, which is fantastic. But remember, there's a coupon available today for 15% off any of our MSRA resources. The most comprehensive package that we do is MSRA Ultimate, and that is a combination that looks at both that knowledge side of things, but also the technique side of things as well. So in this package, for example, you have your live MSRA grammar course. That's a course that we do around a month before your actual exam. We have 2 big video courses, one for clinical and one for SJT, where we go through technique, knowledge, sample questions, etc. We have 14 MSRA mock exams. So again, it's important to do questions generally, but it's also important to do questions in your timed format. So doing these again and again, and getting used to that technique side of things is important. We have 2 audiobooks to allow you to learn whilst you're on the move, traveling, on the go, etc. Again, building up your knowledge base, both for clinical and SJT. And then we have 3 sets of flashcards that are specific to MSRA. We've got your clinical guideline flashcards, your pharmacology flashcards, and your SJT flashcard. This is all the ultimate package. Again, the coupon that's gone up in the chat is CONSAVE. So important to use that coupon today if you want to get a 15% discount on those. And then, like we mentioned earlier on social media, there's lots of MSOA teaching out there on social media. Really important to make sure your passive learning is up to the mark as well. We do quite well with active learning, that I've got 2 hours, I want to sit here and study. But if you can get your passive learning on the rise as well, then you're learning things without even realizing it. So for example, on Instagram or Threads, we do a lot of MSOA type teaching. We have our MSOA Telegram group that hopefully a lot of you guys are already members of, if you're preparing for. Again, we do a lot of daily teaching on there as well, and then a lot of videos on YouTube. Like these videos will end up on YouTube, but a lot of teaching videos are there as well, particularly for SJT, and the clinical side for MSRA. So hopefully you guys can utilize some of those things going forward. So in summary, I've whizzed through GP application because there's so much to cover, but GP is a very popular specialty to apply for. Often people apply for GP alongside something else. So when you do your MSR exam, you're not just competing for those that are going for GP, you're competing with those who are going for GP plus another specialty as well. Plenty of pros and cons, and it depends on the kind of clinician you are. You can probably think about whether you would thrive in an environment like a GP setting, or whether you really want that hospital setting. Again, knowing those pros and cons is important in terms of weighing up whether this is for you or not. You don't want to be applying for GP training without understanding what it's all about and thinking a little bit about, does this suit my style of learning? Or working, I should say. Know the application process, know the key dates. If you're on our MSRA Telegram group or on Instagram, for example, we constantly put out dates for applications, for exams, how many days left to MSRA, etc. So make sure you know your process inside out and then start focusing on MSRA. It's such an important exam because it's not a pass fail, remember, it's a competitive exam. You're going up against your colleagues sitting next to you, you're going up against your colleagues sitting in another country. How well you do on this determines whether A, you get into GP training or not, and then ultimately B, whether you get to work in an area of the UK that you want to work in or not. So really important to focus on some of these key things. So a quick whiz through of GP training. I hope that answers a lot of key questions that we certainly get when it comes to GP training. A lot of you guys are currently in your PLAB 2, PLAB 1 phase, and GP training may be something in the future for you. So hopefully this gives you a little bit of context going forward. And some of you guys are already preparing for the January MSRA. So again, hopefully this gives you some context going forward as well. So I hope this helps. I hope you can answer a few questions and queries that have been coming up in the chat before we go for lunch. So I'll bring Dr. Pooja back in on this. Anything particular, Pooja, that's on there that's important to answer or that you can answer yourself?
So thanks, Suman. Somebody's asked, what is GP with urgent care?
So we're kind of talking about GP with a specialist interest, aren't we? So you can look at this in 2 ways. Urgent care is a big part of general practice work itself. So a lot of GPs choose to work in urgent care as their sole GP work. So for example, you might have urgent care clinics that work overnight or work on weekends, for example. And some GPs who like the more acute presentations, seeing people for the first time, may choose to work in urgent care as a GP themselves. So that's one aspect of general practice. But then you can also be a GP with a specialist interest in urgent or acute medicine. So these are GPs who work in GP for 2 or 3 days, for example, but then they may work in an A&E department as an A&E doctor for 2 or 3 days. So when you look at GPs in urgent care, you have the urgent care work within general practice itself, and then you have urgent care work that's not in general practice, like in A&E medicine, and you can kind of work around how you want to work it best.
Thanks, Suman. So just to cover a few points there, I think it's very important to highlight that general practice, there's a lot of myths around it, but the NHS has got quite a unique healthcare system. So the NHS is based on a primary care and a secondary care system. So primary care refers to general practice. And so GPs are, as Dr. Aman said, your first point of contact when you become unwell. So everyone here in the UK is registered with a GP. And so when you become unwell, you go and see your GP. And if your GP is unable to manage it, if it's an acute situation, they will refer you to secondary care, so the hospital. So if you're acutely unwell, you go to the emergency medicine department or whichever department is relevant. For example, you may speak to the medical registrar on call or surgical registrar on call if it's a surgical emergency. And if it's something more chronic and you need secondary care input, so it's rheumatoid arthritis that you can no longer manage in the GP setting, it is the GP who refers the patient on to see a consultant in secondary care. So it's important to realize that, because a lot of people think GP is an easy option. It's maybe not as senior. The best way to look at GP is that you are a family medicine consultant or a primary care consultant. So it's no less than being a hospital doctor. Of course, me and Dr. Aman are biased. We're both GPs by background. But it's important to understand that system, to understand how GPs work and why it's so important in the NHS. A lot of you are also asking regarding the CREST form. As we mentioned earlier, the CREST form has now changed. There is no longer the CREST 2021 form that is valid for applications. The latest changes is not only is it a new CREST form, but you have to have had your CREST form signed, ready for your application. So when you submit your application, when the application deadline happens, that is also your deadline for the CREST form, and you need to submit it with your application. I mean, I think there was a question about is it necessary that one clears PLAB exams or become a GP first in order to get exposure or registered in the UK and then go on to apply for the MSRA? So I think a bit of confusion there in terms of how the system works. Do you want to clarify that?
Yeah, and I saw that, and there's another question about this as well, about whether you should be doing a non-training job first and can you apply directly for GP training? So let me cover that as well, because those are common queries that we often get. Let's start with should I join training immediately or do a non-training job first? There's no right or wrong in this, and I've seen people who have immediately after passing PLAB 2 essentially apply for specialty training, and that could be GP training as well. Because they're confident that, look, I'm okay with that. I don't feel I need to have experience in the NHS first. I think I'd just be able to be working fine. And then the only challenge that people often find then is that if you get your first rotation in general practice of GP training, and you haven't even worked in the NHS at all, to jump in there could be quite a big jump. So as long as you're comfortable and confident I can do that, there's no reason why you can't apply directly for specialty training. Whereas for that reason that people may worry about going straight into a training rotation, some people do a standalone non-training job, 6 months as an SHO in something first to get the experience of the NHS, at least before you go into a general practice setting. Because if you jump into a general practice setting, not only are you have to figuring out how does the NHS work in general, but also you've got to work out how does this GP setting thing work, and it's quite a big jump for a lot of people. So it's not that you can't do it, but if you're applying for GP training, a lot of people do like to have one job at least in place, so you understand the NHS system. If you're applying for a specialty training program, then you know that you're going to go straight into a hospital rotation already. Then maybe that's something that people don't worry too much about. But if you go straight into a GP setting and you haven't worked in the NHS before, that can be quite a challenge. But what was the first question, or did I cover that one?
No, so it's people were getting confused. Do they have to pass all the GP exams to then apply for MSRA? So just go through
no. Sorry, yeah. It's a really important question to get right. So let's just look at the timeline then. So you do PLAB 1, you do PLAB 2. That gives you GMT registration. Then if you want to apply for GP training at any point going forward, you have to pass the MSRA exam or get a good score in the MSRA exam to get into GP training first. So to get a place as a GP trainee, the MSRA exam is the exam that you'd be doing. Once you're in GP training, to complete GP training, to come out the other side as a GP, you need to complete MRCGP. And MRCGP consists of 2 exams: the AKT exam, Applied Knowledge Test, and the SCA exam, so MRCGP Part 2. So you only take those 2 exams once you're in GP training itself. You can't take those exams pre-GP training, and you can't take them post-GP training, because you can't finish GP training unless you pass those 2 exams. So hopefully that clarifies it up. So the order of exams that you'll be taking is PLAB 1, PLAB 2, or UKMLA, UKMLA, UKMLA 1, 2, MSRA, and then when you're in training, MRCGP AKT and MRCGP SCA. That's kind of the timeline that you'd be looking going forward.
And if you want more information about that timeline, that's covered into how to get into GP training blog, which Dr. Raman has put in the link for. Someone's asked, is the CREST form signed by a UK consultant, is that preferable? No, not at all. Your CREST form can be signed by your consultant abroad, as long as they're registered with a recognised body. That's covered in our CREST form blog in terms of who's eligible to sign. Of course, if their certificate with that regulation body is in a foreign language, you will need to get that translated and uploaded alongside your CREST form. So no, it doesn't have to be. The only criteria is that if you are applying for August 2024, then your CREST form needs to have been signed within 3.5 years within 3.5 years to the August 2024 start date. Yeah. So if it was signed in August 2020, that would no longer be valid. And it has to be the new version of the CREST form, unfortunately. So if you had CREST 2021 form signed, you need to have the new CREST form uploaded with the application. Someone's asked, is this 12 months experience till time of application or till start of training? So it's 12 months post your full registration. So you need 12 months further clinical experience after your full registration. So that's either after FY2 here in the UK, because you only get your full GMC registration after doing an FY1 year. So you need a further 12 months. And that will be at the start of training, because most people apply in their FY2 year for their specialty training, and it's with the expectation that they would have successfully completed their FY2 year for the August start.
I just got seen a question quickly about the MSRA packages. So we have a number of different packages depending on how much input you need in terms of help MSRA. They're all 12 months. So whether you go for MSRA Ultimate, MSRA Gold, or MSRA Silver, they're all 12 months worth of subscription. So we design it so that you can start as early as possible, so you're not worried about subscriptions ending. So if you're doing the exam in January, or whether you're doing the exam later on in 2024 in September, the MSRA package is absolutely fine, because you've got enough time to utilize. And there's lots of information to go through. There's lots of videos, lots of audios, lots of mocks, lots of questions, and lots of flashcards. So the more time you utilize it, the better. And someone said, when's a coupon valid till tonight at midnight? Can't save. That coupon of 15% off is valid till tonight, whether it's PLAB 1, PLAB 2, or MSRA.
And can I just say, based on that, a lot of IMG doctors struggle with the SJT, the professional dilemma paper. It's actually based on the GMC Good Medical Practice, but if you haven't trained here, you may not be familiar with that paper. It's a good idea to look on the HE website. There are some sample questions with answers. We have based all of our questions around the GMC Good Medical Practice guidance. So, you know, we do have the most number of resources out there for the SJTs, but it's a matter of putting that time aside to go through it, because you do need to understand it. And there's certain techniques to answer these questions, and the importance of reading the question clearly. So please do have a look at the HE website with the sample questions to understand how the SJTs are marked and how they're ranked. That's very important, because clinical knowledge as doctors, most of you will be familiar with. But once again, it's about being familiar with UK guidelines, and we cover all of that in our packages. And I think somebody's asking, is PLAB exams necessary to sit the MSRA? No, what's necessary is for you to get your GMC registration. PLAB is one way of getting your GMC registration, but yes, you do need to be registered on the GMC in order to start specialty training. You can't bypass that. And the good news is there's no limits on the number of times you take MSRA. It's important to note that you do need to be aiming to score highly on the MSRA, no matter which specialty it is, but especially for GP, because that is what GP specialty training application is based on, your MSRA score. So please take time out to prepare for the MSRA. You need to prepare, and that depends on your baseline knowledge in terms of how long you need to set aside to prepare.